Thank you, Jamie, and thank you everyone for being here. First, I just want to say how privileged I am to be able to conduct this interview. Rich's leadership at ABIM, at the foundation, and throughout his career has been just marked by this profound commitment to fostering trust and trustworthiness. And he's responsible for driving significant advancements in healthcare delivery and payment and outcomes. And we'll cover as much as we can in the time we have, because in my short time working with him, I've learned more than I could have imagined. He is, without a doubt, the best leader I've had the privilege of working for. He is loving and caring and kind. I'm pretty certain he's all of the things that made him a great doctor in his time. And his dedication to patients, his vision for healthcare, his unflappable courage, and quite frankly, how he shows up every day as a friend, a colleague, or a mentor are why I imagine many of you joined us today. So with that, Rich, I'd like to start as early on as we have time for with your early influences. Can you tell us a little bit about your experience in community practice and your work with the National Health Service Corps and how that shaped your vision for trust and trustworthiness?
Thank you, Jess, for setting all this up, for giving me an opportunity to talk with a community that I care about issues about which I am passionate. And it's a great place to start. The National Health Service Corps. I funded medical school with a National Health Service Corps grant, which seemed like a great idea when I got it in the 1970s. And then the idea was they funded you in medical school, and in exchange, you did federal service in a physician shortage area. And they sent my wife and I from New York City to rural Tennessee, where I was the only physician in the western half of a county. We were the only Jewish people for 3 or 4 counties. It was real culture shock. She went from a Wall Street law firm to being out in the rural South, and I learned a ton about being a doctor. In some ways, it was more important than anything that had happened to me in training. And some things were things that people would know about, that all the good doctors in the world don't actually happen to be located in the academic health centers. And the best general surgeon I ever worked with was on staff at Bradley County Memorial Hospital in Cleveland, Tennessee. So the idea that there were really good doctors there was certainly part of it. But I think the most important thing for me, frankly, was a different vision of accountability than I had ever seen in my training. That in academic health centers, people see kind of two kinds of practice. One is the faculty practice, where the world's expert in B-cell lymphoma comes from one suburb and converges with the unfortunate patient who has B-cell lymphoma from another suburb. And the entire interaction is based on the doctor's skills and expertise and the patient's need. That's a
Mhm.
lopsided interaction. It breeds arrogance. In clinical practice in residency clinic, you're lucky if your patients speak the same language. They're certainly from different backgrounds than you're from. But being a community doctor in rural Tennessee, accountability was very different. That if you behaved like a jerk in the office, you would be standing next to that person in the grocery store line. You would learn that that person was related to your receptionist. You would learn that that person was somebody you counted on for some critical service in the community. And frankly, Jess, I found that inspiring.
Mm.
It was about being accountable to patients, and they assumed we know what we were doing, but they really needed you to show up as a human, and that was deeply anchoring for me. And frankly, when we moved to Philadelphia 3 years later, when Jane got a position at Temple, I wanted to be in community practice, and even though it was a big city, I wanted to bring with me as much as I could of that experience of being connected to patients in other ways than just that they were sick and I was a doctor.
Yeah, wow. And speaking of contrast here, so then you joined ABIM as a director in 2001. Um, what was that like coming from your experience in practice?
Right. So ABIM certainly had and has a reputation of being a very academic organization. And I wound up on the board at ABIM. They were always looking for practicing doctors to be on their board. But to get on the board, you needed a kind of high profile people. It's a self-perpetuating board. People had to know who you were or what you did. And so the board tended to have on it lots of people who were chief of medicine or who were the division director or who were foremost researchers or educators. There weren't a lot of practice people there.
Mhm.
And I had a friend who was on the board who was an academic at Penn, and she put my name forward to become a director. So when I became director in 2001, I was the only person in my own community practice on a board that was almost 30 people at that time. And another thing, interestingly, about me, that because I'd had a career in leadership in Medicaid managed care and was learning a lot of things about Medicaid and about insurance and about organizations, I spent a bunch of time in the 90s not going to ACP meetings and not, and of course I didn't have teaching rounds and all that stuff. I had a very high stakes practice. The patients were my kids' teachers, my wife's colleagues, my neighbors. And so in 1998, even though I had lifetime certification before I had anything to do with ABIM, I recertified in internal medicine because I wasn't sure that I knew what I needed to know to do what I was doing every day with my patients. So I kind of had a contact with the board before I was on the board, but I was the only one who had recertified for the first 3 or 4 years that I was on the board.
Mhm.
So that also was culture shock of I was in practice. I obviously appreciated the importance of staying current if we were going to do effectively what we do with patients, but I was not like everybody else around the table at ABIM.
Yeah, and that appointment ended up becoming a really important one in your career because you later became a foundation trustee and then CEO of ABIM and ABIM Foundation. And together with Daniel Wolfson, who's on the call, you helped and led the ABIM Foundation's Choosing Wisely campaign. Can you tell me a little bit about that, why it was important at the time and what you learned from it?
Absolutely, all kinds of things wrapped up in there. As I said, I had been chief medical officer at Health Partners, a startup Medicaid HMO in Philadelphia. When I started, I was the point 4 FTE medical director, and I was the 35th employee, and we had maybe 4,000 members. When I left a decade later, there were over 400 employees, 100 of them reporting to me as point 4 FTE Senior Vice President for Medical Affairs. And we had 125,000 members in Medicaid and the first Medicare Choices demonstration project. So it was really groundbreaking to be there. But what I learned and the work that I did was using the structure created by Medicaid managed care to try to improve quality.
Mhm.
And the early quality movement, I think most of us in clinical practice are embarrassed to admit this, and many of us don't even know it, but it really began on the insurance side. It was not something we were doing on the clinical side. People are familiar with HEDIS measures. Daniel Wolfson was actually probably the architect of HEDIS measures, many different origin stories. But the acronym stands for Health Insurance Employer Data Information Set. And the concept was that the insurance companies had computers and they could generate numerator denominator data about relevant things. So if a woman had a mammogram, they paid a claim for the mammogram and they knew how old she was. And they knew if she was in the range between 50 and 65, which then recommended annual mammograms. And they realized that they could construct quality measures by looking at all the women Dr. Barron saw between age 50 and 65 who had a mammogram in the last year, which was a whole different thing. As a primary care doctor, I knew that I went to work saying, hey, I think you should get this thing. But I didn't know how many of my patients, what percent of my patients actually did get that thing. And that was true for everything that we did. And especially when we were on paper, it was really true for everything that we did. And that was the most interesting work that I did in Medicaid.
Mhm.
Well, the board got interested in what was then called Part 4, Quality Improvement in Practice. And the idea was let's start thinking about numerator denominator data as a core part of medical practice. And if you think about it, our entire therapeutic guidelines, everything comes from that when we recommend a blood pressure medicine, somebody did a study where they gave that medicine to 500 people and didn't give it to 500 other people, and they counted who did better and who did worse. And then we say, okay, this blood pressure medicine works. And the idea that we could be thinking about practice that way was a really radically interesting idea.
Mhm.
And I was able to do all kinds of interesting things in practice, like when we shortly after we adopted electronic health record, and that's a whole other story. We used to recommend people to get colonoscopies. We'd say, okay, you should get a colonoscopy. Here's why. We give them a phone number and say, call it, make an appointment, get the colonoscopy. Once we were on an electronic platform, we found a GI group that was willing to accept email referrals from us. And with patient permission, we would send to the GI group, hey, here's a patient we think should get a colonoscopy.
Mhm.
And then we were able to do a study in our practice about when we referred people, which mechanism we referred them on, and if we sent the referral to the GI people and had them track down the patients, 40% more colonoscopy completion rate with that. And
Mm.
at the time we did that, there was a publication in the New England Journal, which I think is sort of the ancestor of the Cologuard work, new screening. Some sophisticated new screening DNA technology increased detection rates less than 10%, which was enough to get it published in the New England Journal. And there we were making breakthrough
Mm.
changes there. So on the board, they made me chair, I think because I understood quality improvement and lots of them didn't. And I was the first person who was in his own practice who was chair at ABIM. That when I came on, the chair was the dean of the University of Washington in Seattle, and he was followed by the chief of medicine at Yale. So it was a very academic organization, and I was unbelievably privileged to be able to be chair. And I think it was a combination of having the practice experience and having some of the QI experience.
Yeah. Yeah. Wow. That's incredible. And it sounds like you must have done a good job if they kept you on to become CEO.
They can't fire you when you're chair.
Yeah. Okay. Um, so if we could pivot a little bit to some of your work, and some of what you experience in a leadership role, when did you start to see trust emerge as an issue in healthcare? And why and when did your work start to pivot to this topic?
So I did want to add one more thing before
Hmm.
we talk about that, because your previous question included choosing wisely, and I
Yeah.
didn't talk about that. And I want to be sure we talk about that because that was really important.
Yeah.
The foundation's mission is to improve the quality of healthcare by strengthening medical professionalism. It seems like an airy-fairy movement mission. It's like, what is this professionalism stuff anyway? Fair amount of skepticism these days about how valid it is, even as
Yeah.
a motivating concept. But the idea that people went into healthcare because they wanted to do the right thing, and that we could have affirmative policy strategies designed to appeal to people doing the right thing, that was really interesting. There's lots of ways to make healthcare better. The example I just gave of doing email referrals for colonoscopy, that made healthcare better.
Mm.
Reorganizing care can improve the quality of care people get. Payment structure changes can change the care that people get, but appealing to intrinsic motivation is important. And in choosing wisely, what we realized was there were lots of things we were doing in medicine that were not benefiting patients. And the then Institute of Medicine did a study that if you defined waste as healthcare services given to patients that didn't benefit those patients, then up to 30% of what we're doing in healthcare is waste, doesn't benefit patients. And in a $2 trillion a year industry in America, that's serious business.
Mm.
So the job I had before I came to ABIM was at the Innovation Center at CMS, where we were trying to test new models of payment and service delivery that increase quality and decrease costs for Medicare patients and Medicaid patients. Very similar mission to what was at Health Partners, which was improving the health of a defined population within a fixed budget.
Mhm.
The idea that resource accountability was part of being a good doctor. And it needs to be, because there's no free lunch here, that if we do all sorts of unnecessary services, that results in higher healthcare costs, that results in higher healthcare premiums, that results in lower employee wages. At the state level, a more expensive Medicaid program means less money spent in education. It means less money spent on bridges. It's hydraulic, the relationship between healthcare costs. And if we take responsibility as physicians writ large for being sure that what we're doing is prudent, actually benefits patients, is not unnecessary care, it can have a huge impact on our country and on our society. And
Mhm.
so I think choosing wisely really caught fire, partly because it focused on, hey, what are some things we're doing that we shouldn't be doing? But we launched it at a time that value-based care was just getting started. And with value-based care just getting started, people needed a professionally, ethically grounded way to talk about that.
Mhm.
So if an organization signed a risk-based global payment contract, one scenario is the CFO stands up and says, you all got to stop ordering so many lumbar spinal MRIs. They cost a lot of money. You got to stop doing that. Well, that's not a very appealing conversation for anybody to be having, but a conversation that says, the American College of Physicians, in its Choosing Wisely recommendation, says you shouldn't be doing lumbar spinal MRIs early in a course of a patient with back pain. Now we're talking about something that really makes a difference. So Choosing Wisely was huge, and and I was on the foundation board when it was implemented, but it was really Daniel and my predecessor Chris Castle and our communications department. Lori was on that too. So there were a bunch of people who made that happen, but it basically was something that came along at a time that it was really, really helpful. Now, you just asked me, when did we start thinking about trust and how and why? The experience at ABIM was frankly a shocking experience. That when I took the job in 2013, it was an organization that had a stellar reputation, and I believed I was stepping into leadership of an organization that people widely admired and respected. And within a year, the organization was under substantial attack. And people were saying lots of things about ABIM that were not true, or they were a tiny bit true, but they were way distorted. As we've since learned about misinformation, and that there's always a grain of truth within it, but it gets dramatically distorted, accentuated, and in a way that sensationalizes things. And there were lots of sensational misinformation flying around about ABIM. And our first reaction was to stand up and say, well, that's just not true. I'm sorry, that's just not true. And what we discovered was that didn't help us at all. That didn't work. That what people, well, of course they're going to say that's not true. Of course they're going to disagree. Of course they're going to push back on that. And we had to think very, very deeply about why people would believe things about ABIM that were not true.
Mhm.
Why would that happen? We think that doctors are rational, evidence-based, science-based practitioners. Why would they believe a bunch of things that were not true? And it took us a while to discover that that had to do with us having lost trust with the diplomates,
Mhm.
that we were perceived as arrogant, we were perceived as out of touch. That description earlier of I was the only practicing doctor on a board of 30 people, but all of a sudden, ABIM, in a continuing certification, maintenance certification, time limited certification universe, all of a sudden we were exercising authority over groups of people in the practice world, and they did not trust us. They did not have any reason to believe that we knew what they did, that we were in a good position to set standards for them. And in the period of time that it took us to figure that out, we maintained a position of distant arrogance and omnipotence and omniscience. We know the answers. You don't. We're the testing
Mhm.
organization. You are not. And I think that really cost us dearly with doctors. And so a major part of my leadership when I started at ABIM was recognizing that, acknowledging that. A kind of watershed moment was when we apologized and suspended a part of the program that people found egregiously problematic. And we suspended it because we agreed with them. We were not achieving the goals we were hoping to achieve with that project. But it was an apology, an honest, authentic apology, um, saying we got it wrong, and we're going to work to get it right by building channels of talking to you. And we realized that the only way out of this predicament was to recognize we'd lost trust, apologize, make some changes, and take steps to keep it from happening again. And as we were doing that, and as attention was focused on doing that, we started thinking on the foundation side with the foundation board, hey, wait, the American Board of Internal Medicine is not the only healthcare organization that is perceived as arrogant and distant, not the only healthcare organization that may have lost trust with the populations we're supposed to serve.
Mhm.
And we realized at the foundation that an agenda of building trust, that actually pretty much every healthcare organization, we all presumed that we had trust because we're well-intentioned people. We're using a good methodology. We're trying to avoid conflicts. We're trying to be pure in what we do. But we were not acknowledging how much trust we had lost in healthcare.
Mhm.
And so the program began of building trust, of inviting healthcare organizations to think about making building trust a core strategic priority. And that was how we got there.
Yeah, and it sounds like a lot of what you've talked about has been a real focus on being deserving of that trust, being trustworthy rather than the outcome of trust. And so that's been an intentional focus.
That is exactly right, Jess. And Lauren Taylor, one of the scholars we funded in building trust, taught me that we have to be really careful when we talk about trust. That's something we're hoping that patients will have with respect to us, but that is something we need to earn. Trustworthiness is about the behavior that clinicians and organizations engage in to be worthy of trust, to earn trust. And
Mhm.
at the forum a few years ago, David Williams, a scholar of African American history and sociology at Harvard, introduced us to the concept of earned mistrust, that there are circumstances in which people lose trust, and deservedly so. And I think the ABIM story that I told was earned mistrust. We did earn mistrust from the clinicians.
Mhm.
Well, if you look around at the healthcare delivery system, there are lots of ways we're behaving that are generating mistrust. And that's everything from surprise billing to causing medical bankruptcy to the way we pursue medical debt. These are things that support a narrative that people could have, that at the core of medicine is we are in service to our patients. At
Mhm.
the point at which the patients can believe we're doing this for us and not for them, then we're really in trouble. And then we lose the position we need to have to be able to serve our patients effectively.
Mhm.
And I think there are lots of ways in which we're doing that, and health equity is certainly one of them.
And as you talk about trustworthiness, there's been breaches of trust with patients, with the public, but then there's also been, and we've focused on at the foundation, trust between organizations and the people they employ, their workforce. And so as we've been promoting this work, can you speak to some of the challenges that you've experienced in getting healthcare institutions to care about this, to take the work up?
Absolutely. So I think I still describe us as being at the Paul Revere phase of the campaign, where we're really when we are talking with healthcare organizations, we hear several things. We hear people say, the first thing they say is, "Yeah, trust is important, but we don't really know how to build it or how to measure it," but then they say, "We're not really sure we need to worry about it because we know we're good people. We know we go to work to do the right thing. We just got the state of the art proton beam therapy. One of our research faculty won the Nobel Prize. Of course, when people are really sick, they're going to come to us." So we've had trouble in the way that choosing wisely got picked up as a tool to help people solve the problem of value-based care and new forms of contracting. I think the healthcare system is still a ways from recognizing just how much lack of trust threatens our ability to do what we do.
Mhm.
And I look at the last few years in the world of COVID and the number of people in this country who affirmatively made a choice not to do something that the evidence overwhelmingly suggested they would do.
Mhm.
And if you ask yourself, how could that happen? Why would that happen? Which I think is a really deep and important question to ask.
Mhm.
Well, the same company that brought us the COVID vaccine is the company that brought us OxyContin. And if you live in certain parts of the country, or you have a relative who died in the opioid catastrophe, you're talk about earned mistrust. You have reason to be skeptical of
Mhm.
what that company, what that series of agencies are telling you.
Mhm.
And it's not, we can't undo that history, but we can't pretend it isn't there. And I think that across healthcare, people talk about, one hears a lot about Tuskegee, which I have learned better to refer to as the study of untreated syphilis in Black men, the U.S. Public Health Service study of untreated syphilis in Black men, because we don't want to tar the Tuskegee Institute with what happened there. But people talk about that. People talk about Henrietta Lacks at Hopkins. These are clearly breaches of trust. These are clearly things that have had an impact on the way communities think about whether the healthcare system is taking care of them or not. But the fact is that health equity today, disparities in care today, differences in why do Black women get kidney transplants at a lower rate than Black men, at a lower rate than white women, at a lower rate than white men. What is that? And
Yeah.
it turns out that's not about cultural beliefs and it's not about organ supply. It's about structural racism.
Yeah.
And if you are a Black or brown person, you look at the healthcare delivery system and you say, I'm not sure I'm going to get a fair shot there. In fact, I have evidence to believe I won't. So I think that earned mistrust is very potent. And I think healthcare organizations need to take seriously what contributions they've made to
Mhm.
earning mistrust and do what they can to both apologize, make restitution, and make changes that will help them in the future.
Yeah. And and it matters for health and health outcomes. We saw this year or last year a National Bureau of Economic Research paper that linked trust with as predictive of health seeking behaviors as income and education, which is pretty remarkable. And so, and you've spoken a little bit about the spread of medical misinformation. Can you tell us a little bit more about the impact this is having on our healthcare system and strategies that healthcare professionals can use to combat misinformation and trust in evidence-based medicine?
Absolutely. And as we engage in the Paul Revere campaign, the Paul Revere phase of the campaign, I think people's susceptibility to misinformation, people's willingness to believe outlandish, outrageous things is a testimony to the lack of trust that people have in authoritative sources of information.
Mhm.
And I think that um, at the end of the day, what makes people believe conspiracy theories, what makes people believe things that are preposterous, it's all about a lack of trust and a way that people are connecting the misinformation to an alternative universe explanation that gives them a sense of comprehension, control, and community. This summer at the forum, Dana Young, who will be one of our speakers, she'll be addressing this issue. But the whole idea of people have needs for comprehension, control, community, you when you feel like you don't have those things, the idea of a a something being part of a larger narrative that you think helps you make sense of the world, then the fact basis of it doesn't matter as much as how much it helps you connect. And it's it's a it's a scary and dangerous way for us to be making decisions, either health policy decisions as a society or individual health decisions as patients.
Mhm.
That very bad things happen. We at the end of the day, our method of generating knowledge within healthcare is fundamentally a statistical method. It's fundamentally, if you do this, you're more likely to get a better outcome than if you do that. It doesn't mean everybody who does it is going to get a better outcome. And it doesn't mean that everybody who doesn't do it is going to get a worse outcome. But it means if you're trying to chart your course and you want to maximize your chances for health and flourishing and success,
Mhm.
paying attention to that kind of information, it makes us smarter as a society. It makes us healthier. It's a safer way to go. Um,
Mhm.
I'm less likely to die in a car crash if I'm wearing a seatbelt, but I can drive all over the place and not wear a seatbelt and not die. But if my goal is not to get maimed in a car crash, wearing a seatbelt is a good plan.
So thank you for that, because you've explained for us why it matters as a consumer of healthcare, as a patient, and you've explained to us why it matters as an institution, as an employer, as an organization. Why does trust matter to the average leader in a small practice or the average practitioner, um, who's just going about their work every day?
Well, I think there's lots of pieces of that. That the average practitioner going about her work every day thinks that on some level it's about her. I'm trying really hard. I'm being nice. I don't have any ill intention toward my patients. But she needs to realize that every patient she sees brings in baggage from previous experiences with the healthcare delivery system with other doctors. And that could be everything from her uncle was killed by a medical error, to her cousin was misdiagnosed, to having been mistreated or disrespected because of her race or ethnicity in a healthcare setting. All that's going to come into the room,
Mhm.
and the same authority that that clinician is drawing from and is relying on to be believed, to be respected, to be listened to, right there with that are all these other experiences that say, actually, no, don't do that. And so I think a fair amount of humility for people at the care interface, and acknowledging that not everybody's experience is our experience, and being curious about what that is and being open to learn about what that is, because at the end of the day, we train to put our expertise, we as clinicians train to put our expertise in service of patients, in service of the predicaments they have. We need to
Mhm.
understand that we can't be effective clinicians just by knowing the science. We need to find ways to connect as humans, where the Tennessee experience was so helpful for me.
Yeah, and thank you too. You've outlined the healthcare trustworthiness theory of change that we've co-created with the Institute for Healthcare Improvement, and we're hoping to have more information about soon for folks. But you spoke about apology or acknowledgement, recognition, uh, uh, reconciliation, closure, and building systems. Anything else you want to say about that process or what you've learned about it?
So I think it it is a process that, first of all, is deep within us. I you know
Mhm.
the I'm I'm Jewish, and we spend the holiday of Yom Kippur thinking about who we've injured and how we can make it right and how we can try to figure out how not to do it in the future. That's a liturgy that's thousands of years old. That's my particular tradition, but I think that tradition lives in lots of other forms. And if you look around, if you think about the patient safety movement, one of the apology and reconciliation movement of, if there's a medical error, instead of clamping down and shutting up and clamming up and saying we're not going to say anything, if what you do is approach families and say we this is terrible, but we did this bad thing, and we feel terrible about it, and we'll do what we can to make it up to you. um, that has been shown to reduce litigation, not increase litigation, which is one of the things people are afraid of. In a very deep human way, we want to connect authentically with people, which involves acknowledging mistakes, which involves apologizing for them, which involves doing what you can to make it right. And I think we need to figure out a way to bring that into healthcare as a structural property of healthcare, because we do make mistakes, and we have made mistakes, and we need, as institutions, to show up authentically in our communities. And the other aspect of this, and you mentioned this before, and I didn't follow this thread, but clinicians within healthcare organizations also now increasingly have track records of how the organization did and didn't protect them during COVID, how the organization did and didn't support them during COVID. There's been a lot of mistrust created between healthcare organizations and the teams that actually deliver the healthcare. I think that's another very fertile area for healthcare leaders to be thinking about, and I think it can be helpful in everything from trying to address moral injury and burnout, to helping with staff retention and staff recruitment. Authenticity, it is prized, and acknowledging that one makes mistakes and doing what one can to fix it, is, I think, a pretty basic and expected human reaction.
Yeah, but not an easy one. And
No,
so,
no, no, it is not an easy one. Think marital arguments. The in before the ABIM apology in 2014, 2015, read a book on apology, which educated me about the "I'm sorry if" form of apology. I'm sorry if you think
yeah,
I this. Very familiar. Any marital quarrel and any political apology, and I think trying to reckon with taking accountability and responsibility for what we get right and what we get wrong, it is core to being an effective clinician, and frankly, a praiseworthy human.
yeah. Of course, I don't know what you're talking about. I've never.
No, no marital arguments
No,
there,
no.
right? Yeah. Yeah.
So before I pivot to some of the questions that are coming in the chat, I do have a self-seeking question for you, which is advice you have for ABIM, for the foundation, for your successor, Furman McDonald. Anything, any words of wisdom you want to pass along to us?
Well, the first words of wisdom are to express my absolute confidence that you, Jess, as EVP at the foundation, and that Furman McDonald, as CEO of the board and the foundation, have the skills, have the moral center, have the passion, have the leadership strength to lead and steward both of these organizations. And when you face retirement, as I am, and you worry, gosh, what's going to happen? I know what's going to happen is going to be good, because there are strong, ethical, wise leaders in both organizations, and I have full confidence, and I know that they will face different problems. You will face different problems than I have faced, and you will bring to them the skills you need to solve them. It's not about how we did it in the past; it's how you'll do it in the future, and I think that's critical. I I found myself a lot during my time at ABIM when things would get difficult and challenging, thinking back to a patient I had who was a customer service supervisor for Delta Airlines the year that Delta Airlines, that Hartsfield, which was Delta's primary hub in Atlanta, melted down and ate everybody's luggage over Christmas weekend. And he came to see me the week after that. And I asked him, I said, how do you do your job? Like, how can you possibly? He said, it's pretty easy. He said, I tell all my people, it's not your fault. It's really not your fault. And not only that, I tell them, you're the only person who can help them find their luggage. You didn't lose their luggage. You're the only person who can help them find it. So I think anybody in leadership today is going to be subject to a fair amount of obloquy and criticism. And I think social media has completely taken off the gloves of there's just no such thing as civility in any kind of discourse. That's how it is. It's regrettable. It's sad, but it's how it is. And I would encourage people, first of all, to understand what is within their scope and what's not, and what they are responsible for and what they're not, and to be willing to apologize if they do get it wrong, which doubtless each of you will, and we all will, but also to recognize that the world is imperfect and you're in the process of trying to make it better, and to tolerate some of that imperfection even as you work toward making it more perfect. And that would be the guidance I would give to both you and Dr. McDonald.
Thank you for that. So you've given us advice. What about if you're just getting started? If you're a healthcare professional who's early on and who's passionate about all the same things you just spoke about, what advice do you have for them?
I, I continue to believe that no matter what the changes and transformations are in healthcare and in medicine, that there is a fundamental atavistic role for physicians and patients that never goes away. The best definition of medicine as an activity I ever read was in a book by Ed Pellegrino and David Tomasma called A Philosophical Basis of Medical Practice. And it defined medicine as an intersection of two intentions, one seeking help, the other offering it.
Hmm.
And, Hippocrates, you read that stuff, the airs, the vapors, what does that have to do with me? Like, what am I supposed to, you read the 18th century leeches and whatever else, what does that have to do with me? I think that the common thread, the historical continuity that is medicine, it's a continuity of purpose. And that purpose is to put you to spend the hard work and hard time and hard effort learning about illness and disease and suffering, and learning what tools are available to ameliorate that, and to commit yourself to offer that knowledge in service of people who need it.
Mhm.
That's what's at the core. And I don't care what the payment system is, and I don't care who owns your practice, and I don't care whether it's private equity, and I don't care whether it's venture capital, and I don't care whether it's a federally qualified community health center. There will be a series of obstacles you will face in trying to deliver on that promise. And your job is to get past those obstacles and be the hero that being a physician is. It's a heroic profession. I think people feel a lot of moral injury these days. They feel a lot of disrespect. They feel a lot of burnout. I feel like it cuts them off from the heroic narrative of being a doctor. And when I say that mindful that inbox volume tripled, mindful that physicians don't control their own fate every day, but physicians have an unbelievably privileged opportunity to interact with people at times of grievous need, and it's profoundly fulfilling. And I wish people a joyful career as I have had.
Oh, that's beautiful. Thank you so much for that, Rich. And I think we're right at time to start asking some or getting some questions from the audience for
Great.
folks on the line. Jamie, what's coming up?
Allison just put a question in the chat and she asked Rich, wondering how you think that the growing role of emerging technologies in healthcare will impact trust.
So I think technologies always change healthcare. The stethoscope is a technology. The X-ray is a technology. Laboratory medicine is a technology. And each of those things wind up being tools that skilled clinicians can use to alleviate suffering, which is what it is we're supposed to be doing. I think it's about how we use those tools. And I think that people, both doctors and patients, approach technology with skepticism, suspicion, some amount of fear. The emerging technologies, which look more and more human, they look scary all kinds of ways. But I think fundamentally, the problem, the challenge isn't any different than one that medicine has coped with throughout its life. Of the technology becomes a tool to fulfill that goal that is medicine, and trust is about how we use it. It's not about the technology itself. And of course, we need to explain the technology to patients. And anybody who's been through an MRI and listened to the clicks and bangs and whoops, and people need to understand how that connects to the challenge that they have. That's on us to explain why we think that's a good idea. But I don't think technology fundamentally transforms what we do.
Great question, Allison. And Diane is asking, she appreciates the Tennessee reflection, and she's wondering if you find that patient trust has a connection to the perception of quality.
Um, that's a great question. I think that one of the things about the perception of quality is, uh, first of all, I think patients assume it's there, and we'd love to be operating a delivery system where they're correct to assume that. Mostly we do, but not always. Lots of comparisons between commercial aviation and healthcare, but I don't spend a lot of time worrying about how well trained the pilot is when I get on a plane. I'd love for healthcare to be that way, but we know healthcare isn't entirely that way. But I think patients a lot of times entering hospitals act like I act when I get on an airplane. They assume everything's going to be okay. So I'm not sure how much quality, in the sense that we define it like safety and the numerator denominator data I was talking about. On the other hand, quality, like, do people call you by name? Do people introduce themselves? Do people explain things in terms you can understand? Do people make an effort to reach you where you are? I think that's an important part of quality too. We're not as good at measuring it. We haven't formally defined it as well, but I think the doing of that is something that patients rate very highly.
And I think Mark Linzer has done some work on this, which we can find and try to put in the chat as well.
Yeah.
Hazel is asking, are physicians aware of their implicit biases and how this plays into providing healthcare?
Well, I think certainly patients of color are very aware of health equity issues when they approach the healthcare delivery system. And I think that, again, I had an experience when I was in practice, early in my practice, when I was still comprehensively doing reviews of systems and doing absolutely comprehensive physical exams. And I even had a consulting room, so I would do the exam in one room, and then I'd sit down with a patient in the other room after they got dressed. And I was taking care of an African American sign painter. It was the first visit. He was about 60. And when he sat down in the consulting room, the first thing he said was, Dr. Barron, if I were a United States Senator, would you have done anything different with me than you just did? And it was like, why are you asking me that question? Like, I don't have anything against you. But clearly his experience was he could not rely on the healthcare delivery system. So I do think people are aware of it. And I think the challenge comes from when clinicians say, "Oh, not me. I'm not prejudiced. I don't have any biases." And I just think, we need to get over that. Of course we do. And
Yeah. And I think we're learning now that implicit bias training is not enough to move the needle. It has to go further as well.
right.
Um, any other questions, Jamie?
We've received a few submissions during registration, so I'll read one of those. Often the discussion around cultivating trustworthiness implies a static or neutral information environment. What can the health system do amidst an adversarial and at times anti-expert information environment?
Oh my goodness. Um, so I think that I've actually just started Renee DiResta's book called Invisible Masters. And the title is from a quote um, from a guy who invented or who was one of the early US propaganda people in World War I, of working with the Government Office of Information to try to help develop messaging for people to support the war. Um, it's a very, very, very vexing problem. There are clearly communication techniques and communication skills that can influence how people think and what people believe. And I think that we are living in a world where those tools and those skills and those platforms are being weaponized in ways that are not well understood. And I don't know that we have the regulatory tools or the conceptual tools to know how to set boundaries on this stuff. At, at a minimum, I think healthcare needs to realize that communicating in monographs and communicating in 40-page PDFs of text is not an effective way to reach people, and frankly, less and less even an effective way to reach clinicians. That we need to take seriously that modern communications technology has implications for how we communicate information. And we need to become better as information communicators than we are. And I think we need to approach that in healthcare with the same level of seriousness that we approach laboratory quality control, that we need to build into what we do a recognition that part of being effective it is figuring out how to use those platforms, those communication technologies for public good.
Thank you, Rich. Question here from Bill Adams. He's quoting Victor Montori's work about moving from a transactional to a relational environment and how ABIM could help to allow physicians to practice the kind of healthcare where they can best meet their patients' needs.
Well, I couldn't agree more that transactional to relational is a transformation we need to make. And my friend and colleague Krasinski talks a lot about that, and I completely agree that is something we need to get past. I think in terms of what ABIM's role in it is, as the board, um, we are just starting to explore using emerging technology to assess physicians. Once we get out of a mold of single best answer multiple choice questions, we start to be able to assess different aspects of physician behavior, clinician behavior that may be more relevant to what you're describing. And I think we'd like to get there, and I think we could get there, and I think that would be value based, or that would contribute value. But I also think health systems have a huge role in this. That one of Chuck Kylo tricked his electronic health record to, on the landing page of a patient, display the pronunciation of a difficult to pronounce last name. So every person who saw that patient knew how to pronounce the last name. We don't think about using technology transmit information that would allow patients to be recognized and seen. And then it wouldn't feel as transactional. It would be, oh, wait, you actually know me. So remembering, oh, your daughter got married last weekend. How did that go? Somebody could be asking that on the team if technology was putting that forward. So I think there's a lot of ways we're going to be able to solve this problem. Right now, we don't have a lot of tools. I wish we had more.
I'm going to have to, unfortunately, have one last question to end our time together. But before I do that, I want to ask, I'm scrolling through and seeing a lot of familiar faces here. Folks, to please chat in one word that best describes your time working or learning from Rich. And Rich, the question is from Dan Litzinger. He's asking, what's your favorite memory that comes to mind when you think of your past 11 years with the foundation?
Wow. Oh man, there's too many of them to count. There's a power failure in Utah where, because we were going backpacking after I happened to have a headlamp, that was a pretty bright moment. Um, there are in organizational planning here, we run meetings internally. There was the time the Chief of Staff, Judy Kessel, put who had which month first on a ping pong ball in her dryer, and later inside a balloon that we popped at a staff meeting. So there have been many joyful experiences. They're all around people. They're all around people being their best selves, and really too many to count.
Thank you so much. Grateful, caring, kindness, inspired, hopeful. I'm sure they're still coming in. Thank you. Thank you for joining us today, Rich. Thank you for your service, not just to ABIM and the foundation, but to healthcare as a whole. Your impact is immeasurable, and truly, truly, we're grateful.
I have had a privileged career, and what I would say to everybody out there who's at the beginning of career, none of it was planned. All of it was following passion authentically. If the next job is climbing somebody else's ladder, don't do it. If it's something you authentically care about and you have values congruence with the organization, go for it and go all in. I've had a very fortunate, very privileged career, and you all are part of the community that has sustained it and supported it and made it possible. Thanks, Jess and the ABIM Foundation team, for creating this opportunity to have this conversation. It means a lot. Thank you.